Well, I'm here with Tommy Liu, interventional cardiologist from Hagen Hospital in the Netherlands. He was actually, I think, the first who was very quickly certified for QFR user in one of our courses, and since then a very happy, I believe, and also enthusiastic user of our software. So I'm very pleased also that you are here. This will be the first interview here at the PCR, and we like to make this a little interactive and hear from you what your experiences are so far with the QFR, how you like it or do not like it, and how you see that evolving also in the future.
Okay. Well, basically, we started using QFR in a research setting because in the Netherlands it's not yet a clinical tool for most hospitals. I think not even one hospital at the moment. So we use it as a research tool just to see if we get the same results as the other ones in other studies in other countries. So I saw the studies from Sanford 2 and also joined the Favor 2 trial just to see what happens with lesions when I do just my own angios and compare it with FFR in clinical practice. And I also compared it with a separate database for myself just to see if I don't use the prescribed angulations, do I still get the same results?
Yeah.
What I got was that the results were exactly the same, regardless of what kind of angles I was using, just using my own standard protocol for angiograms, and the results exactly like all the results presented in the cases all over the country and all over the world actually. So, and even after joining the Favor 2, I think it only strengthened the position of seeing how QFR can actually make a difference in the future, because at our center we're doing about 650 FFRs a year, and I think I'm good for about over 200 myself, just annually. And if you compare those numbers and even think about that, about over, I think more than half of the FFRs are above 0.80. You're going to see that a lot of patients are getting an FFR ending up not needing revascularization.
Yes, yeah.
So I think if you...
So that could also be an enormous cost saving for the hospital.
Exactly, and it's not just cost saving, it's also safe, not having to use a wire.
Yeah.
Not only that, the patient discomfort, and of course there are some new things on the market, like we're using IFR as well, next to FFR, for the patients who can't use adenosine, and it saves the discomfort for the patient as well. So basically if we do IFR, we just save on the discomfort, but we still have to use an expensive wire, we still have to pass a lesion. But that's something you rather do when you're sure you're going to perform the PCI directly. So for a diagnostic angiogram, you rather not pass the lesion with a wire if it's not needed, because if you damage the cap and you damage the lesion itself, you have to perform the procedure at once. But usually those patients aren't, they aren't prepared for PCI, with medication needed. Yeah. So if you can do it for lesions that are able to perform QFR on, you don't need the wire, you don't need the medication, you just do your basic angiogram, just like you do always, and you add 4 minutes to the time of the procedure just to perform the QFR on, and seeing that the results are exactly the same as the FFR numbers.
So in terms of practice, who does the QFR? Is that the technician in the control room at this point in time? I mean, this is still kind of, let's say, proof of concept, so to say, in your hospital, or do you do it yourself? How does it work in your...
Well, at the moment we said, well, because we have to check if the quality control is still up to par, I'm doing it myself, and we're going to train my colleagues as well to perform the QFR, but for the time being we're not going to train the technicians to perform the procedure itself. We're going to keep that in our own hands for now. Yeah. In future, if we're all up and running, we might have to train the personnel as well, so we can stay at the patient side of the cath lab, and the personnel can do the analysis, and we just check on the screen if it goes correctly, so we can do like the other in the old days when you do a QCA. Yeah. You let the technician do the job, and you check if they do it right. Yeah. I think that's possible with QFR also in the near future. But for the time being, we're keeping it because it's also for research purposes, and we didn't start using it as a clinical tool yet.
Yeah.
We said, well, we have to keep it in our own hands for now.
Yeah.
But in the future, yeah, we already decided to use it as a clinical tool, so that's going to start soon.
Well, that's very happy to hear. And of course, very important is that you get the proper angiographic views. I mean, you have a lot of experience. We developed this wizard also in the software.
Yeah.
How useful is it, or do you say, well, I know which projections to take for the particular case?
Well, I think for the less experienced user, I think the wizard is very useful, just because you do your first base angulation, and afterwards you can see where you have to go. If you're experienced with QFR, you just do it by basically by sort of automatic feature in your own head.
Yeah.
And you make your angio, and you know which organal view you need for the next next view to do your QFR on. So that makes it easier for yourself, and it doesn't cost you any time because it's already in your mind what the next projection will be.
Yeah.
But that's only for, I think, the more experienced user, and for the beginning users, the wizard is excellent just for them to be guided.
Yeah. Yeah.
But there are, of course, lesions, because we're talking about the difference QFR, FFR, IFR. Not all lesions are suitable, of course, for QFR, as well as you don't expel the wire in totally. But there are a lot of lesions that you just don't need a wire for. But if it's too much tortuosity, or you just want the wire to do the work, and it's done.
Yeah. No, we don't say that you don't need a wire anymore.
Yeah.
We think that with our solution, we can increase the physiology use in the cath lab, and maybe to 60 or 70%, and there will always be cases where you still need a wire, and whether it's FFR or IFR, that's fine.
And it opens up the possibility to do much more physiology testing for the patients which you do diagnostic angio on. So if you look at cost saving, safety, comfort for the patient, it all adds up. So for the lesions that you're so sure of that they're well validated in the bigger studies, it's over, I think, 3,000 patients already.
Yeah.
And if you see that they just match the FFR numbers, and even the other ones, other techniques don't match that well.
Yeah.
And we're already using those techniques as a clinical tool, because of the bigger studies like Define Flare, etc.
Yeah.
So that's one of the reasons we decided, well, why shouldn't we use QFR as well? Of course, we're going to use this clinical tool, but in the meantime, also joining the FAVOR 3 and a local database for ourselves, just to see what the clinical outcome will be. So basically, we're doing in parallel the clinical outcome studies as well as using it as a clinical tool. So we said, well, if we wait even 2 years longer, if you have to wait for the results of clinical outcome studies, then you're going to undertreat your patients for 2 years. You're going to overuse resources for 2 years, and you probably end up just using more money and time and doing a lot of more redo procedures without the need for the patient. So I think we should start in time instead of just wait for all the studies to come.
As you know, we need to do the study. I know that you have very good and enthusiastically contributed to the FAVOR 2. And we are now soon starting on the FAVOR 3 outcome study, and look certainly forward that you can also again enthusiastically contribute to the FAVOR 2, the outcome study. So there continue to be lots of opportunities. We also work close by, so we can easily visit each other and like to learn also from all your experiences, things like the frame selection. We have had discussions about that. We should try to simplify it further, and all your help there is also much appreciated.
Well, we're going to hear a lot more tomorrow for the FAVOR 3, so hopefully we can start soon with that.
Yeah, excellent. Well, Tommy, thank you so much for your contributions now and in the future also. And with that, I would like to conclude this interview.
Okay, thank you.
Thank you.